So, hi everybody. We're going to have our session now, and then we're going to have a break whereby we'll be able to discuss and chat with people that you might know or not. I will be the timekeeper. And the session we're about to embark on is going to be very interesting and important. We're going to speak about public policy and how does literacy in the healthcare sector and knowledge play a role in reducing inequalities, that is, social equalities in the field of health. So this is a session that is very important for our agency. The agency has already started working on literacy in the healthcare sector. And so there is a thought process that's ongoing at the moment. And we're thinking about the concept itself and how we can implement this concept. And there have been studies aimed at documenting and understanding what health literacy actually means, because it does determine inequalities in the healthcare sector. And it's quite a recent approach in France, actually. And as such, there's a lot of work going on in order to document the phenomenon, to see how it can be used as a driver or used as leverage to fight against social inequalities, as well as it's the focus of our advocacy. And one of the challenges in the field of healthcare is we need to make sure that literacy in healthcare is present, and it's an important part of our national healthcare strategy. So it's a concept that applies to quite a large community. So you're here today, and you come from different horizons. The people are you in associations, health agencies, those who work in the field, doctors, nurses, all those involved in public health care. And it just reflects the importance of this topic. And it's also a part and parcel of the way we communicate and our communication campaigns, because we address the entire population. And we need to make sure that the campaigns are heard, and regardless of our social differences, it's our responsibility to make sure that we communicate with everybody and that we address everybody, and that we are especially attentive to those who are the most vulnerable. And it's because of our interest in this field that we partner with the Reflis network, who will be presented to you a little bit later. And we wanted to tell you about the studies that have been done within Santé Publique France, and the work being done by colleagues from our neighboring countries, whether it be Switzerland or Belgium, all of those who have been involved in studying health literacy and have been doing so for a long time now. So altogether, we're going to take stock of the knowledge. We're going to present all the works that have been done in order for us to identify competencies and skills amongst the population, and anything that entails health literacy. So that's the institutional part of it. On a personal level, it's something, the topic of the discussion is very important to me. It's not something that I work on every day. I don't work on healthcare literacy every day. My remit is a little bit different. But I did discover the work being done in this field when I was based in La Réunion at the University Hospital, and I worked with Xavier Debuche, who will be with us this afternoon. It was a real discovery for me, and it was quite innovative at that time. There was a whole team working on it, and so I saw the birth of the Reflis network, and I saw the research team that then joined ranks with them working on this topic. It's a team I know very well, and I've been working with them for several years. So on a personal level, this is something that's very important to me, and I'm very much vested in the content of this discussion. And I'm going to try and make sure that everybody, all the participants, have their say this afternoon. So I'm going to hand over the floor to Philippe Martin, who's now going to tell us about the Reflis network. Hi, everybody. I hope everybody can hear me. I'm going to be very quick, and within the next 2 minutes, I'm going to be telling you about the Reflis network. It came about by an initiative of Virginie Ranguet and several researchers who, since 2016, have been doing studies on various topics relative to access to health and well-being. The network is supported by Santé Publique France with a collaboration of different researchers in different disciplines involved in different projects and working with different research laboratories. And they talk about anything that relates to health literacy and digital literacy or organizational literacy. So several studies, the results of which will be presented to you today on the topic, and experiences by different population groupings and determinants, which we will put emphasis on in the field of healthcare. And together we'll discuss about the impact of literacy on people's lifestyles and on the individuals. So the aim is to know to which extent literacy can be integrated in how we understand law, life, and the REFLIS network has been working on different angles in terms of access to healthcare and health strategy, as well as how do we take measurements. A lot of studies have been done on the basis of questionnaires and trying to assess literacy from different angles and according to different aspects. So some of the results will be presented today. There's been many because it's a very extensive network. And we hope you enjoy the contents of this discussion this afternoon. So thank you, Philippe, and thanks to all the members of the network. Thank you for having joined us for this session, which will be based on partnerships. And I'm Cécile Aller, and I focus on access to healthcare literature and information. And I work with Annie Velter, who is co-chairing the session with me. And in order to open up the discussion, I'd like to call upon Caroline Stomack, who teaches at the Institut et Haute École de Santé La Source in Lausanne, Switzerland. And so thank you in advance, Coraline. Tell us about the concept and the link between health literacy and health inequalities. So hi, everybody. And today I'd like to tell you about health literacy. This is a tool for reducing inequalities. It was just a part of a small part of the thesis that I've just completed and that I will be presenting to you today. And so I was asked to just introduce a slide about conflict of interest. And health literacy is something I'm very much interested in. But I'm going to begin by telling you what health literacy actually means. I'll give you a general overview of the concept, and then I will go on to tell you what the link is between health literacy and health inequality. And I will be telling you different points for consideration, and I will conclude my thoughts at the end. And so all of us are confronted with issues relative to healthcare. We have to take decisions when it comes to our own health. So, for example, when do I need to see a doctor? Do I have to be vaccinated? What should I eat? How can I eat healthily? And in order to make an informed choice in a healthcare system that's becoming increasingly complicated and complex, we need to have information. We need to have access to this information. And informing yourself about your health means having several capacities and skills. You need to know how to read and count, and you also have to have a critical mind. You need to know how to think critically. So what is health information exactly? It's all types of information relative to health and has an impact on somebody's health. It's information that is of different types and is relative to all the different fields of healthcare. So for example, it could be information relative to the treatment given, diseases, the way the human body works. It could be user manuals for the drugs and any instructions provided by healthcare professionals or any signs or posters in the hospital. In the field of prevention, disease prevention, it's all information that relates to health risks. So, for example, the different vaccination campaigns, information on different screening campaigns, or information relative to how you can prevent domestic accidents. When in the field of healthcare promotion, it's all that relates to health determinants. So just to give you some examples, it could be information on sports and physical activities, eating healthily. And on an organizational scale, it relates to information that regards the way the healthcare system works and healthcare coverage. So all different things of information and the rights of the patient. And apart from the fact that information spans across all the different fields relative to healthcare, it's communicated via different channels, and there are different means to communicate. And so it could be verbally when there's an interaction. It could be an individual or group interaction when you're speaking to a healthcare professional, or if you're having a discussion with your family or members of your entourage. It could also be written media. It could be posters, the magazines, articles, via the different audiovisual tools like TV adverts or radio adverts, and via different IT media, digital media, could internet, mobile apps, social networks, and it could also be different advertising campaigns, adverts that either come from the food industry or pharmaceutical industry or any other industry, the cosmetics industry. So what is health literacy? It's a multi-dimensional concept, and there are different skills. It enables people to have access, understand, assess, and apply any health information. So in order to access, it means that they've got to have the capacity to look up information, to find and to obtain healthcare information, like being able to ask questions to your doctor, looking up information on the internet, or being able to discuss with members of your entourage, or you can hear people speaking about certain healthcare-related matters. And it means the capacity to make sense about this information, which means being able to ask for clarification or specification. It means being able to interpret, select, and have a critical view on healthcare information. So what that means is being able to assess the overall quality of a piece of information provided to you, to see how reliable it is, to be able to compare different pieces of information amongst themselves, or to think whether the information relates to you, if it's appropriate for your situation. And in terms of application, it entails being able to use information to make a decision about your own health. So these are 4 skills that are important, because this is how we're able to judge and make an informed decision when it comes to health, which means that at the end of the day, you can have a better quality of life and a better state of health in general. And health literacy is a result of different individual aptitudes. It entails having knowledge, being able to make decisions, having a critical mindset, being able to solve problems. And health literacy is also something that depends on the context that we evolve in. So it's influenced by our surrounding environment, such as the economic context, the political context, and the social context, but it's something that's also influenced by the healthcare system itself. So health literacy is influenced by accessibility, not only financial accessibility, but geographic accessibility. And it can be influenced over the time. So it's something that can be conveyed via a doctor during a medical consultation. And it's also something that requires communication skills, and means healthcare professionals need to communicate. And it also depends on the complexity of the information that they are communicating. So health literacy means striking a balance between one's own individual aptitudes and reconciling this with the requirements and of the context. So just to give you a very simple example, you can collect information, nutritional information off packaging is a very different story to getting other complex information communicated to you via a healthcare professional. And so it's there's a very big difference, and the requirements and the context of the situations are not quite the same. And so why is health literacy so important? It's because being literate will have an impact on your state of health. There are several studies that have shown that being literate in the field of healthcare gives rise to benefits for somebody's health. It means being more actively involved in your discussions with the healthcare professionals. It means having better preventive behaviors and adopting more positive behaviors for your health, and better observance of your treatment, and just better health in general. But when somebody is low skilled, it also has very bad consequences on the person's health. Means that they will suffer from more chronic diseases. They don't follow their treatments as effectively, higher mortality rates, and sometimes they don't make appropriate use of the healthcare services. And so this has a negative fallout on their overall health. And so the negative impact on health can be a worry. It depends on how many people are concerned by this issue of not being literate. There have been several studies carried out in the US and in Europe and in France and Switzerland have shown that 50% of people are not literate in the field of healthcare. So it's becoming increasingly important to be literate in this field, especially in today's days and times. And so it's something that should be taken into consideration because it also gives rise to inequalities in the health field because we all are not at the same level of health literacy. There was a study carried out in Europe. It was a survey carried out in 2012 in 8 European countries, had already brought to light that people who are socially and economically underprivileged were especially vulnerable, and there was a link to being illiterate in this field, and so these people, as such, tend to be less healthy. It was a European study which also highlighted the existence of a social gradient, and it was noted that there's a link between where you're located in the social hierarchy and your level of health literacy. So the higher up you are in the scale, or the lower down you are in the scale, the more risk you have to be more illiterate in the field of healthcare. And so health literacy is linked to health inequalities. There have been several initiatives, actions, and strategies that have been carried out throughout the world trying to reduce the gap and reduce inequalities in this field. But unfortunately, these continue to exist. And so there was the theory of fundamental social causes, which was developed by Link and Phelan in 1995, which said that social and economic inequalities give rise to health inequalities. And so there are various intervening factors, and so it depends on your material conditions, working in unfavorable conditions, or having limited access to resources, and notably to the healthcare system, all has an impact. And so these inequalities you also have people who are in a better or worse position on a socioeconomic level. People who are in a better position have better access to healthcare. They also tend to have better knowledge of conditions required to keep up their health, and they have better access to the resources that they'll need. And as a result, they are more informed in terms of their choices and tend to be in a better state of health. And so several authors have stated that health literacy is an important driver. And so the link between socioeconomic status and literacy wasn't very well understood. And so I reviewed all the literature, aiming to clarify the place that, or the role that health literacy plays in the mechanisms that link socioeconomic status to health inequalities. And in my review, I also included all those studies that explored the socio-demographic and socioeconomic factors that were the most often associated with low levels of health literacy, as well as studies that examined the potential role of a mediator in health literacy, so between socioeconomic and social status and health inequalities.
16 articles were included in the review, and the results have confirmed, without any surprise, that a social status, socioeconomic status that is underprivileged does contribute to low health literacy. Main factors being the level of education, revenues, employment, perceived social status, ethnic belonging, and gender. The results also confirmed the role of a mediator in health literacy, even though partial, in relationships across the social and economic factors and inequality in health. Okay. So the association there across the characteristics here, on one hand, can be compared with the inequality in the health status, health results, quality of life, and access to healthcare. The influence of an underprivileged socioeconomic status on inequalities in health can be explained partially by low levels of health literacy. Now, to go further, there are two other studies worth discussing. The first one being Jürgen Pelikan and et al. Study, published at the same time as the reiterative review I talked about, the analysis from the health literacy survey in Europe, the study I mentioned a moment ago. And the analysis of the secondary data show that health literacy measured functionally, based on the definition that I presented to you earlier. Hold on, I got this wrong. Health literacy, when it's measured functionally, meaning to read, writing, counting, applying to health care, in fact, is a mediator of the relationship. However, the health literacy being measured multidimensionally, as the definition I presented you, is an independent determinant that directly impacts health. Another study conducted in the integrative study, it was an Italian team, conducted a study on the population to explore the role of a mediator, of health literacy as a mediator in healthcare, by measuring it functionally, measuring health literacy functionally, and it confirmed the mediation of health literacy and between health and also revenues and health. And also what was exposed by the study is the mediating effect was higher for people of the lower socioeconomic categories. So in conclusion, health literacy, be it mediator or determining factor in health, these three studies show that health literacy is a potential driver for reducing inequalities, can be used as a means of taking action to achieve greater equality in healthcare. Studies focusing specifically on underprivileged people, socioeconomically speaking, can increasing their literacy can help there. However, health literacy was not considered as a wonder miracle solution to health inequalities, because health literacy will not have the power of modifying or changing their socioeconomic situations. So health literacy needs to be considered as an intermediary strategy to offset the impact of socioeconomic inequalities that can also be at the origin of health inequalities. So we have to tackle the root causes, though, such as inequalities in education, employment, and revenues, as programs such as those combating poverty. Thank you, Coraline, for that very educational presentation as a mediating effect or direct effect of health literacy to health. A couple of minutes now for Q&A. Any questions either from the audience or from people who are online?
Certains d'entre vous avaient des questions.
Non, je regardais s'il n'y avait pas Laurent Rigal dans la salle parce que c'est.
I was just wondering if Laurent Rigal was out there, because there's a client recently who conducted a study to determine whether you had the mediator or modulator effect in terms of HL, health literacy. I was just wondering if you had any knowledge of other studies along those lines, and is it very dependent on be it functional or multi-dimensional measures? It depends on the measurement that's used. In fact, the main limit of my integrative review is that the studies were mainly American, measuring health literacy functionally speaking. So I see that there's a mediating effect in the studies that were included in my review. So Jürgen Pelikan in the health literacy survey tested all three assumptions, determining a moderator and mediator. And so the relationship is much more complex than it appears, because when health literacy is measured multidimensionally, there's a direct determining impact using the only measure of subjective health. But they've detected also when it's measured functionally, health literacy is expressed through various moderating and mediating effects. Therefore, the relationship between underprivileged and health through health literacy, the relations of health literacy is much more complex, and we just don't know anymore at this stage.
S'il y a peut-être d'autres questions, peut-être moins techniques aussi.
Maybe some other questions are technical, maybe some general questions on the concept. I was just wondering if the literacy concept holds for other sciences or other topics like law literacy or economic literacy, or is it something that's specifically health related? Well, if you take the first word, literacy, of course, you can roll that out to other fields. There's just so many, I can't even list them all. But from my standpoint, what's presented today can be transposed to other fields. We consider health literacy. In Switzerland, it's actually considered a life skill. So I'm assuming that with a little bit of imagination, you could transpose that to other fields. So literacy is also explored in other studies. Internationally speaking, we have got other issues. We've got media, digital literacy, about 30 different areas that are not as far advanced, though, as health literacy. Just remember, though, that literacy was first used by people interested in education. We don't know the word in French. It's not literacy, but illiteracy, the opposite of that, of course, in education. So we have not used this much, with the exception of people who are looking at education from the illiteracy standpoint as opposed to illiteracy, with all the stigmatism that carries with it. Thank you for that. No questions there from our remote viewers? We'll have some more time for Q&A in the general session later if any come to you. Now let's welcome Professor Julian Mancini. Professor at Cestine, University Aix-Marseille. Corinne mentioned the European study. So Julian, you'll be telling us more about the study that was conducted in France. That's right. Thank you. That was a perfect introduction, because I will be presenting the results from the new European study called HLS 19, focusing on the French results. I'm from Cestine. Let's see, a research center in Marseille. So this gives you a bit of context to explain that France had participated in the study that was mentioned in health literacy survey that Coraline mentioned. Had tons of projects in the RIFLES network that we just heard about. Lots of research, but no real stock taking internationally. So just had some data, which was the VCON study, and that was cancer survivors, and it was summed up in just a few questions. It was mostly functional literacy. And then recently, a few weeks ago, we saw results from our another European study on health that gives you the health literacy questionnaire modules that focuses on understanding functional aspects, showing that 1 out of every 10 people had difficulties understanding what this was all about. So we've talked a lot about this. This is the functional dimension. It's just one part of health literacy. Do I have a pointer? I guess you can see in the circle, that's what Coraline presented to you. It's not just about understanding. There's access to information, there's appraising the information, and then applying the information to improve one's health. And then the idea of the European group was to say that it's not just within the health scope, but also impacting disease prevention and health promotion more generally. So along those lines, that's what drove the HLS study. 17 countries across the WHO countries, not only European, but you have Israel in there as well. And it was headed up by a consortium from Austria called MPOL. And the data collection, the data compilation was you had a maximum number of countries, and it was up to the country with the goals of a sampling of 1,000 adult respondents, representative in terms of age category and place of residency. So France came on board a bit later, went to the simplest online survey conducted by an Ipsos panel with 1,000. We had the first wave in 2020, and since it was COVID-19, we went with another wave, wanted to go with another wave later and see what happened post-pandemic, but we didn't really get to be post-pandemic. We had 2 waves of 1,000. So then the questionnaire that was used, part of it was there were fixed answers in the European study with the literacy and general health, using a 12-item instrument where you had 4 skills times 3 different fields where this could apply, some demographic information, demographic and socioeconomic features, and then state of health and behaviors regarding healthy behaviors, or health-related behaviors, and 3 optional modules. These were more specific aspects in health literacy, being able to navigate through the healthcare system, being able to communicate with physicians, and then digital literacy is what we added in the second wave. Adaptation in French, the questionnaire was in English and German, as we had professional translation for Switzerland and Belgium. There was already a consensus meeting there to come up with a common wording. So we focused on the difficulties or facilities perceived, and on a scale from very easy to very difficult. Is it easy for you to find information and say healthy lifestyles, or as regards physical activity, or a balanced diet, healthy diet, and general literacy questions, focusing on access to information, healthcare promotion. So you have some examples there, and all of the questionnaires were available freely. Just needed to ask MPOL, the MPOL consortium, to get them. So if we look at the results, they're quite diverse. Not just understanding. We have an average score of 77.5 out of 100, and we have 44% of the French adults who consider that they have an insufficient level of literacy. So 30% having a problematic level. If we look at the comparisons here, it ends up being relatively similar to the 17 other countries participating. So here's some 4 questions. You can see that the answers are quite different. No difficulty there at the bottom to follow doctor's directions or pharmacist's directions, or to understand the information. More difficulties when assessing risk and benefits in different treatments, or knowing how to protect oneself from diseases and prevent diseases, and from information available in the media. So specific interest for this group to determine a social gradient. In France, we have this type of gradient. There's no real difference regarding gender. Nothing linear as regards age. However, we see that these perceived social status is excellent and higher perceived higher literacy, all the way down to and the financial difficulty is much more frequent there for the inadequate and problematic levels. You can see logically training, information, and health promotes literacy. Diseases and long-term health issues seems to be less linear, but these are often inadequate levels. So we said, on one hand, you have the consequences, and there are multiple causes here. You can see the same results here. Better literacy, better health literacy is associated with favorable preventive activities, daily fruits and vegetables, greater physical activity, so better perceived health. You see that on the graph there, the connection between perceived health, and the categories of the various potential scores on the scale with the relationships here that you can see, and it's a very strong relationship. Okay, I don't have time to go into all of the details here, but just wanted to focus on digital technology here because this is interesting for us. Here's some results as regards health literacy, digitally speaking. We can see there's more difficulty for the respondents. The average score drops to 54 out of 100, and down to a good 3/4 of the respondents are considered at an insufficient level. So this compared to what we saw earlier, the difficulties here are frequent for even the questions that are not problematic when, for instance, consulting several different websites. Becoming frequently over half of the respondents had difficulty for over half of the questions up the top there to determine whether there are commercial interests behind information available on the internet, and then also judging the reliability or the accuracy of the information found there. You can also see a bit of a gap that we didn't have earlier. Looks like more difficulty in France than the other countries. So the two are connected, but not that strongly. So there's a correlation at 0.6. And it depends how you look at things, but we can consider that that's relatively independent there. And it does make sense to measure this separately or maybe conjointly, health literacy and digital health literacy. But from the MPOL network, this gives rise to other questions and perhaps even targeting the problems and then generating specific actions to correct those jointly. Now, to describe these difficulties that were particularly important, there's an accumulation of difficulties, those regarding the health field, but also other fields, digital and media, the internet specifically, and then to explain why they seem to be particularly outstanding in France. We don't have a lot of avenues here for development. The study was online, so maybe that means people who should have had a better score. We didn't have the over 75-year-olds in France, so that's something that should have given us better results. But our results are actually lower than the others, so it's something we need to look into and figure out.
Donc en discussion, vous avez vu, voilà, qu'on a...
And so, as you see, there were various difficulties that we regularly encountered. Like I said, the sampling should have been in favor of having a good literacy score. In terms of the limits, the questions that were used were quite complex. And so this enabled us to reduce the ceiling effect that we have in this type of survey. But it wasn't very applicable for those in more underprivileged settings. And that's why for the field surveys, there are other instruments that are better suited. It's not that one is better than the other, but different contexts require the use of different instruments. And so it was a survey carried out across the board, but it didn't prove to be representative because it was based on a method of quotas and it wasn't a real random sampling. And another downside was that it was done during the COVID pandemic. And in terms of perspectives, we need to probe further with the analyses to better understand the data collected. And we also need to take a look at what's happening after the COVID. There's a team that's already looked at the data from another panel, another survey called the Slabaco survey, but there hasn't been really major differences that have been noticed. So the European survey will be repeated, and so we're already thinking or starting to think about what the next series will be. What will be the contents of the next survey be, and in which case we will try to correct some of these limitations we faced with the last round of discussions. So in conclusion, we were able to pinpoint the difficulties, and we could predict that we could conclude that there is a social gradient, but it's sometimes difficult to predict. So we said that everybody needs to be considered as at risk. And those who have better health literacy mustn't feel insulted when they receive documents or information that they feel might be below their level. But it's important for everybody to understand. And, of course, this is very much linked to behaviors. And so there'll be a lot of examples that will be given after the fact. But we need to step up and multiply our actions at all levels. And like Caroline said, this needs to be done not only at the individual level, but at the organizational level. And we need to adopt a systemic approach to fight against social inequalities. And we tried to look at the different types of difficulties, and we saw that there was no, there was a heterogeneous set of results, and but even so, the difficulties experienced in France are pretty much the same as the difficulties that were being experienced in the other participating countries. So I'd like to thank everybody, Santé Publique France and the League Against Cancer, who financed the survey, as well as all the other parties that participated. There were many. If you want more information, the report is accessible. And in the fall, the results of the survey will be published. So thank you very much for listening to me. Thank you so much, Julien, for your presentation. It was extremely clear. And this is the first time, actually, that we are hearing about the results of the survey, even if the results themselves were released a few months ago. Thank you very much for the focus on digital health literacy, especially in an age where digitizing, especially healthcare services, has been accelerated. And we have room now for a few questions, if anybody has some questions that they would like to ask of our speaker. Anybody in the room? So I just wanted to take advantage. We got a question via the text, via the chat, to see if these presentations will be made available. Everything will be published online and be made available to our participants. Thank you very much. I'm Guillaume Bajan, and I worked on HLS 2025, and this was a topic that was broached in 2019 already. And what we're planning is to extend on the study in 2025. So thank you very much for your presentation. And what struck me was the graph creating the show between a correlation between perceived state of health and actual state of health. And I'm just wondering, how can we interpret this as having a causal tie to somebody's state of health? And people who are in a better healthy condition, does that necessarily mean that they understand all the medical information provided to them? And so does that automatically conclude that they have a better degree of health literacy? Well, I try to insist on the fact that this is a transversal survey, and I know that a lot of our models say, a lot of our colleagues say that we need to push it to show even the downsides of all of this. But of course, we always have limits, and we try to make adjustments. We try to adjust and choose our criteria. so that when you're in a real-life situation, you do realize that the information can be a lot more complicated than you might think. And that's not everybody understands everything, that there are some difficulties in understanding, especially it can work both ways. And so there was an arrow on my graph, but it doesn't represent a causal tie. I wanted things to move, and so I did talk about the limits in proving the causal tie. And they have other works that have been carried out and other prospective works to be carried out. And so I know that the results here are open to criticism, but I wanted to show them to you nevertheless. So hi. The two presentations spoke about a social gradient and a link between socioeconomic factors and health literacy. Has any studies looked at what's happening on the lower levels? Those are specific categories where people have linguistic difficulties, where they are socially fragile. And for those population groupings, the approach needs to be a little bit different. I know that we have other colleagues that have really worked on more underprivileged population groupings. And that's why I wanted to say that the questionnaire wasn't very well suited to different population groupings. And with this type of survey, there are certain things that you overlook. And so that section of society that needs more assistance and help tends to be overlooked. Those who are on the fringes of society tend to be overlooked. I know that the Danish, they oversampled and had more migrants in their sample study to try and highlight the effects on underprivileged societies. We didn't look at people's level of education. And when you do look at people's level of education, that gives rise to other types of results. I don't know if Xavier would like to add anything. So there are two other surveys that were carried out amongst people who living in emergency shelters during COVID, and also nomadic people. And so there were surveys that were adapted for them. And the results have recently been published or will be published. And so there are various initiatives that do exist and that we can share with you. So I have two questions. Do we have longitudinal data that can give us an idea of stability over time and to see if things are evolving or moving? And have you got a correlation coefficient between the two different scales? Well, that was part of the plans that we had, but it was something that was never actually done at the end of the day. There have been longitudinal studies to study the long-term effect and to take measurements, but as far as I know, there hasn't been done one on a wide scale with repeated measurements. And of course, when people start falling sick, that can change your level of literacy because you think you master certain pieces of information that you don't. And we don't, as far as I know, have this type of data in hand. This is something that's missing. But there are more field-type studies, like the HLQ study, for example. And there they take a closer look, not on a wide scale, but they look to see exactly where things can change and what can be improved. And so there are longitudinal aspects, but it doesn't exist as a consistent observation. I was hoping The survey was amongst the general population, but especially in cancerology, we send surveys to patients, and so we limit the questionnaires insofar as possible, and we try to identify things that are differentiating. Otherwise, you can measure different types of literacy, but 0.6 is actually not that bad, and it's logical as well. And the different aspects, and I think the link to the navigation scale was a bit higher or not as high. Well, it was higher with digital technology, but lower for literacy. It really depends on the country. Well, yes, it does. And the results were different in the different countries. And if I may, I'd like to just answer the question about the longitudinal data. We did the HLS in 2015 in Switzerland, and in the same framework as the study carried out here in 2019 and 2020. And things are getting worse in Switzerland. So the situation has gotten worse. And navigational skills, for example, in Switzerland, are a lot more disastrous than general health literacy and digital health literacy. And when you asked about the social gradient, there was a study that was carried out in Switzerland at all. I know a little bit. I know the Swiss literature a little bit better. I can't remember the results exactly, but it was a similar study and assessed health literacy levels amongst migrant populations. And they compared migrant populations, the privileged part of the population versus the underprivileged part of the population. The main author was Roidin. But I don't remember the outcomes exactly, but it was a study by Roidin, if anybody's interested. So we don't have any questions being asked remotely. Any questions out from the room? Now, is there a threshold? What are the thresholds whereby we categorize things as being sufficient or insufficient? And so how do we measure how literate somebody is in the field of health? Well, the thresholds are very complicated, actually. The idea is always the same, though. If you want to trigger political action, you need to talk in terms of percentages and say a certain percentage of the population has such and such a difficulty. There's quite a crazy algorithm that they use in order to compare and produce these comparisons. But we need this. And so the average score, it's not really that interesting in itself. It's more when you compare the four different indicators. There's literacies in navigation. There's competencies or skills in communication. The results themselves are quite logical, but the point is to provide a basis for comparison. And so the score actually gives you a general idea and a basis from which to compare. We have other questions, but that mainly involve the thresholds and the scores. At this point, so we're going to go on to the next presentation. So a big thank you to our speaker. And now we're going to hear from Roxane Ajus and Xavier Dubuche. Roxane has a doctorate at Santé Publique France, and she works in non-communicable diseases and trauma. And Xavier Dubuche, who I asked to come and join me on the stage, and he works. He's a diabetes specialist, and he works at Max Quérien University Hospital in Paimpol. And they're going to be telling you about the Entrée3 study. It's a national representative control sample of diabetics, and it's a quantitative and qualitative results, the value of a mixed study. So thank you very much. Thank you very much for giving us the opportunity to tell you about the interest of having a mixed approach to the study and how we applied this in the Entrée3 study. So to set the context for you, I suppose you're all wondering, what is Entrée3? And And so what did the study entail? It was a national sampling representative of those with diabetes. This was the third edition of a transversal study carried out amongst diabetes patients. And it was paired with NDS. It was carried out by in association with the CNAM, the High Authority of Health, and the ANSM, and Santé Publique France. And after a draw from the health insurance databases, the respondents were asked to fill out some questionnaires. We gathered 5,537 answers, 3,166 in metropolitan France, and 2,371 from the overseas territories. All of these were weighted on the basis of various participation biases. And so the respondents were adults living in metropolitan France suffering from type 2 diabetes. And today I will tell you about the results that were achieved within metropolitan France. So how did we explore health literacy in Entrée 3? It was done on the basis of the HLQ, the Health Literacy Questionnaire. This is a questionnaire that calculates an independent score for 9 different categories, 9 different dimensions that were explored. And so there are 4 dimensions that I will tell you about more in detail just afterwards. And so health literacy was explored also via qualitative interviews that Xavier will tell us about in a moment. So very quickly, those with type 2 diabetes, there were 2,714 participants in our sampling. 55% were men, and the average age was 67.6 years of age. Less than a quarter were treated with insulin and had been suffering from diabetes for an average of 13 years. And on the scale, we can see the 4 different dimensions that we studied within the study. So the first one was within the remit of HLQ3, actively managing your health. Then there was HLQ6, capacity of engaging with healthcare professionals. Then the third one was HLQ7, is navigating in the healthcare system. And HLQ9 was the last one, was understanding the information about your health and having enough knowledge in order to know what to do. And for each of these dimensions, the participants had to answer several questions, following which we were able to calculate a score for each of the 4 dimensions. So for HLQ3, actively managing your health, the score was out of 4. And for the others, the score was a mark out of 5. On this graph, here we can see the average scores for those with type 2 diabetes in France metropolitan area. And so the score corresponds with the dimension at the end of the axis. And with this graph, we were able to identify differences between different subgroups of the population. After adjustments according to age and diabetic treatment, we realized that the score for health literacy correlated with certain variables relative to people's social status. So what we have here, if you look at the level of study, what you can see with the red dotted line are the average scores for those with type 2 diabetes. That's the group I just spoke about. And in blue, here we have the average score for those having done at least 2 years or more of university study. And in orange is the average score for those who never went to school or who never finished their primary schooling. And so visually, you can see that those who had never went to school, their scores tended to be lower, whereas those with a higher level of education, their scores were higher. And on this graph, we could also see that those people born in France have average scores that are in line with the average score for those with type 2 diabetes, whereas those for the people born abroad tend to be lower.
People considering that they cannot succeed without debts and that have lower scores than people considering that they are comfortable financially. And then finally, people considering themselves satisfied with the support of their family and friends regarding their diabetes have average scores with lower scores, say, than people who declare that they are satisfied or more or less satisfied with the support. network. So these data can be presented differently to spotlight people with extreme needs. If we look at our sampling of type 2 diabetes in continental France, in large cities, we have these high percentage of people who are 45% who do not have enough information to know what to do, 44% in the metropolitan areas, difficulty navigating through the healthcare system, and about a quarter of our sampling of the French population of type 2 diabetes patients in the metropolitan cities have difficulty in committing or engaging actively with healthcare professionals and actively managing their health. So this gives us an assessment and enables us to have some simple messages for the situation in France. And so this data is added to the data of the qualitative interviews. So I'll hand over to Xavier for the information, further information on that, on the mixed study. Thank you. Thank you very much to Santé Publique France, Laetitia, and everyone for organizing this study and in this additional session called How Public Policy Can Leverage Health Literacy to Reduce Health Inequalities. It is quite an undertaking. Now, let me present. First of all, let me introduce the subject to you and then expound on this regarding the issues at stake. Now, addressing health inequalities through health literacy can be done. We saw this in different ways. And it is done in different ways, but the different ways are all complementary. I'm sure you're all familiar with this bell curve, which gives you the breakdown, the distribution of the population of various individual characteristics based on, say, an average. We talked about that, and standard deviation. Now, regarding health literacy, we now have studies, surveys, and across the general population. Coraline and Julian talked about those, and this enables us to have an idea of what the health literacy is across the general population with the average levels. So we talked about the limits of that as well, and especially this very important study, the MPOL European study. We saw that and completed by the 2019 study in France that shows us the connection there between general health literacy and certain characteristics such as socioeconomic issues and inequalities. We saw that the address just came out with information on HLQ9, which measures health literacy that's functional, that's perceived, i.e. understanding information to better manage one's health. And it shows a certain connection and with variation with the level, with the amount of studies, education, socioeconomic levels, and perceived health levels. Now for us, looking at health literacy and the connection to health inequalities is looking at two types of data, like as Roxanne said, quantitative data from questionnaires as presented to you, and qualitative data from interviews that are the semi-directive interviews carried out in 5 French regions: Greater Paris, Brittany, Auvergne, Rhône-Alpes, Bouches-du-Rhône, and the Reunion Island. So 85 interviews were conducted, looking at social practices of type 2 diabetes patients in connection to access to information, understanding, decision-making, and human resources, personal resources on one side, professional resources on the other end, and healthcare elements, generally speaking. So type 2 diabetes perception was analyzed based on 8 variables to figure out what was important to the people in managing their disease: food, eating, physical activity treatment, monitoring, health knowledge, access to health care and health knowledge, relationship with healthcare professionals, and then finally, social support from one's network, friends and family. So there are very different connections to these variables, and it just shows the complexity of psychosocial skills, medical dimensions of the disease, and the chronic disease patients have to manage these on a daily basis in their with their disease. So benefits of the proper diet, exercise. This is all well known, not always practiced, but so treatment and monitoring of the disease, in fact, gets sustained attention, but it's mostly connected to the HCPs. They need confidence, they need trust, with the expertise there, with these a referent HCP. And very quickly, what we can see from the Metropolitan study is that the diabetologist, diabetics specialist, it tends to be the poor cousin here because often absent or not accessible. Knowledge is variable, a lot of uncertain, a lot of unconfirmed ideas regarding the disease, the medical expertise, and also the human dimension and the quality of one's relationship is sought after with the HCPs for the patients and their health and their healthcare journey, and the family and friend support network is really important, from family and friends as well as from health care assistants and aides. Considered very important. So the study then gives us its anthroposociological view. I didn't conduct the study, but the conductions were carried out by my team, people on my team, Delphine Baillet, and with Mary Bed from Debouche. And so the importance of the influence of some of the variables, especially the level of education. It's not representative, it's qualitative, right? But you look at a panel of different profiles, and there's a lot of difference regarding these determining factors, but they're not necessarily 100% determining in terms of the proper management of the disease. This can be combined, though, with the data from the questionnaire that could be considered multidimensionally, as Julia mentioned. With the HLQ, we can look at these different profiles in health literacy, not just liaison studies, but per hierarchical cluster. And you can look at the patient profiles, or the people who are really struggling, or look at the dimensions from other variables, such as a socioeconomic status. This way, you can look at you can cross the data. It's really interesting. If you look at these profiles and the qualitative data that you can leverage to work both on the metro proximity in a team, in a department, in a community, or an association, as opposed to the meso level where you have the patient journey, and the macro level, i.e. institutional, work on facilitating actions to increase literacy and increase access, and decrease, of course, then inequality. So we want to invert the curve. So we'd have to look through the peephole here, and we have to look closely at these people who are struggling, and as opposed to looking at them statistically, or say following statistic studies, maybe looking at the people who are really struggling, be able to assess their needs in terms of health literacy, the contexts that are different. And in France, in various regions, we know, and we've seen this in the qualitative study, also based on the geographical location, the socioeconomic situation, we can see substantial variations, but you have to take into account local knowledge to be able to think about co-building, co-constructing actions that can be implemented. Now, of course, the National Strategy 2023 has stressed the need to develop health literacy as a major determining factor in prevention and control of chronic diseases. National development projects in health literacy that have been implemented, described in the WHO report from December 2022. In fact, these are tackling vulnerable populations. It can be cultural minorities or linguistic or migrants or refugees, living with disability, aged children in schools, for instance, or in aging populations, and also mental health situations as well. So studies are ongoing looking at the development of health literacy projects in co-construction there. And by connecting this report to the WHO, we'll hear more about this at the roundtable discussion with Yomen and Yasmini. So it's implementing being part of a European project with this JECARD. It's a joint venture on cardiovascular disease and diabetes. So it's a base here regarding methodology. And they've been working on this for several years. The Australian Richard Osborne team in Australia that we've been working with. In way of a conclusion, if I still have time, allow me to come back to the concept of health literacy. It's not just regarding an individual, their abilities and skills, and the ability to adapt and adjust to a context. It's community-based, it's society-based, we should be society-based before being medical-based. There's also responsiveness in health literacy. What we need to be doing as healthcare professionals in the field, on the ground, we have to organize, we have to talk about it being organizational, and it also has to be helmed by public policy as well, and politicians. Thank you.
Merci beaucoup. Alors, on est en train d'essayer de faire une intervention pour que vous ayez un peu plus frais.
I'm trying to get a little air in here because I think it's kind of hot in here. Just so I can understand, I'm Roger Toussaint, president of the League Against Cancer. Generally, when we see results presented, we tend to exclude the overseas territories. I think 5,537. You had 3,166 from the continental, and you had 2,670 of the overseas territories chose to not present the results for the overseas territories. Plus, we're talking about diabetes. We know that the occurrence of diabetes is much higher in the overseas territories than in continental France. So try and shed some light on this for me because I don't get it. I didn't have time to go into that, but honestly, I was just in Reunion Island, and I was working with the French West Indies a lot on diabetes in Martinique, so know that. Antred has been looking specifically at the overseas territories, and the qualitative study, the complete qualitative study, which is continental and overseas territories, it will be coming out soon. It's completely finalized. It's just a matter of getting it published. But you will have all of the answers there. But overall, basically speaking, as regards to quantitative level analyses are currently underway, and they're not quite completed for the overseas territories yet. But what I can say is overall, what we have is we can say there's ease or facility in for diabetic people to accept a good, healthy diet and exercise. Now, as regards to relationship to HCPs, healthcare professionals, there's an advantage that people rely on. That's trust, confidence in HCPs and in their doctors, on one hand. On the other hand, there's the ability to engage with HCPs, which is substantial. But there's huge disparity across the overseas territories in navigating through the healthcare system based on access. So you have to be careful to not draw the same conclusions across the overseas territories to Reunion Island and the French West Indies as well. They can be completely different. We did look specifically at that. Now, quantitative as well, and even more at Santé Publique France. But proportionally speaking, there were more questionnaires in the overseas territories compared to continental France. I'm going to let the two of you continue your discussion during the break. Now, let me give the floor here to this gentleman for a quick question. Hi, CRS and Reunion. I had the same question on the overseas territories because I was surprised that we didn't have those results. Well, we're getting used to that. We're starting to get used to that. But my question is, health literacy connected to socioeconomics and the gradient there, the impact on HL, health literacy, and behavior in health behavior. It exists, but there's no root cause. There's no causal relationship there. So my question is fundamental. By trying to impact health literacy, are we not missing the battle? We're moving away from a huge section there that's important. And I think that's socioeconomic inequalities that are the foundation of everything, because health literacy won't reduce socioeconomic inequalities. I'm not sure if you understand that. Let me increase the challenge, asking for a short answer, even though I know we could discuss and debate that for 3 days. Absolutely agree. Absolutely agree. Using health literacy and carrying out and conducting actions, implementing feasible, relevant, long-term actions. That doesn't mean we should avoid or not handle socioeconomic inequalities. Health is not the only determining factor. It can be a means to analyze, to think, to reflect more on socioeconomic actions, taking into account health literacy. But certainly we cannot not address socioeconomic inequalities. Okay, we will then let you continue your discussion over coffee. You have a 10 minutes break. Thank you to our first speakers.
So welcome back to the next roundtable discussion. And this time around, we'll be providing examples of what we heard about earlier. So as far as the process goes, we're quite tight for time. And so we're going to just hear all the presentations first, one after the other, and then we'll leave time for Q&A relative to all the discussions after that. Well, no. Let's do this again. We're going to first hear the two presentations and 10 minutes for Q&A, and then we'll have the next set of presentations. And so for the next roundtable, hang on, we'll get there. There's a bit of confusion. Stick with us, bear with us. And so there's Claudia Adamagno, who works for the Center for Epidemiology and Population Health Research, the CERPOP, and she'll be telling us about the DECODE trial. So, hi, thank you very much for the presentation. And so I'll be telling you about the DECODE. And that's for the detection of colorectal cancer in underprivileged areas and the influence of health literacy. So I hope everybody can help me. It's a project that was financed by the ALCA. It's a 4-year project. So we're in the 3rd year of the project. And today I will be telling you about what we did in the framework of the study. I'm not going to be telling you about the results because it's a work in progress still. And so just to tell you about the general context, it's the second most diagnosed cancer in France, colorectal cancer. And there's a detection program for people between the age of 50 and 74 years old. But healthcare data shows that participation in the screening remains relatively low. In May 2018-2019, the participation was only 30.5%, and it went down even further in underprivileged areas. And in some of the departments, we had participation rates that were as low as 22%, which leads us to conclude that there is a low level of literacy, and that contributes to a low level of detection in these areas. And so the target of our project was to understand the impact of having mixed interventions. It included both GPs and patients. And the aim was to improve the detection of colorectal cancer as well as health literacy in underprivileged areas. And the project was carried out in 4 French regions, in Occitania, PACA, the Île-de-France region, and the Aura region. And so we had a qualitative study, a qualitative approach. And this is something that's also been envisaged for the future, but I'm not going to tell you about that because I don't have enough time. But what I would like to talk to you about is the type of measures that were instituted within the framework of the study. The study itself and the way it was designed, we drew inspiration from a study that was carried out by Ferreira and his team in the USA in 2005. And it enabled us by following a community approach, it enabled us to collaborate with the local CDCs. And so there was randomized control tests carried out in clusters, so that it was mixed interventions and randomized control. So we had 8 clusters in that total with 32 GPs and the patients. And so there were interventions amongst GPs speaking about how they detect colorectal cancer and health literacy. And there was also an intervention with patients. So there was a brochure with images and an explanatory video on the importance of detecting colorectal cancer and details about the test. And so the final objective was to detect a difference there was a 15% difference of participation between the 2 arms, with the inclusion of 1,024 patients. So as regards having a mixed intervention, and for the physicians, there were 3 stages. There was an initial session, which was an individual session where each physician underwent online training courses. And so we created those, we provided for them, and it dealt with 4 things. There was the testing, health literacy, detection of colorectal cancer, and the principle of clear communication. So the second session was an interactive session involving members of our project, and we also had group discussions with groups of physicians. And during this session, we spoke about techniques and practical advice on how they can approach detection of colorectal cancer for their patients. And then after the 6 months, we had a 3rd session, which we called the booster session. And it was a kind of a reminder. And the aim was to refresh the memories of the advice they'd received in the session before. And it was also an opportunity to speak about any issues that they GPs encountered during the first part of the trial. As regards the patient part of the study, the doctors who participated in the study provided 2 visual supports. So there was a leaflet which we designed, and it was a leaflet that explained how we detect colorectal cancer, how we do it, why you have to do it, and why it's important. And it came with an explanatory video, a video that was available online and created by Anka, and which gave a very clear and simple illustration of how you do the screening test. And so the intervention in itself was put together on the basis of 6 strategies. And so, unfortunately, I'm not going to be able to tell you about all the strategies because I don't have enough time. But I'll tell you about the 4, which is the verbal strategy, the written strategy, the strategy based on calculations, and the visual strategy. There was also a part of the strategy which aimed at patient empowerment and providing a supportive environment. So those are the two strategies that I won't go into detail. As regards the verbal strategy, what we told the GPs was to make use of non-medical language with their patients, to talk to them in current language, everyday language, with days that they can relate to speak clearly and slowly, to limit information to 3 main key points at the most, and to repeat information, as well as to make use of a system. It's a method. It's called the teach-back method, and that means asking the patient to reformulate and to repeat the information that's just been provided to them by the doctor or the physician, just to do a very quick check to see whether the person you're communicating with has effectively understood the message. As regards the written strategy, this involved documents to be provided to the patient, and what we suggested was the documents must be easy to read with very short phrases, less than 15 words long, and using the active voice. And so I've given you an example of the type of text that this can include. So I can't actually see it, so my apologies. I won't be able to read it out to you, says our speaker. But I could summarize by telling you that everybody has a right to be hosted by an establishment without any differences made, and always with respect for each other as provided by the law. And so the aim here is to really avoid using language that is too complicated, keeping things simple and short, and making it easier for anybody to understand. And if the forms to be provided to the patients, it should have boxes to ticks rather than open-ended answers where the patient has to write out their answer, with all keywords in bold, accompanied by drawings and illustrations, and also including the block of "I don't know." This enables the doctor to understand that when it comes to certain other points, the patient didn't understand the question, or maybe very often patients don't dare to say, "I don't know." So that should be provided as an option. When it comes to our method of calculation, the idea is to express probabilities with natural frequencies. Instead of talking about saying things like 90 people out of 100 will be cured if we detect the cancer early. And so all concepts need to be explained as clear as possibly, as simple as possibly. And patients mustn't be scared of the concepts, because they will understand the concepts. And one last strategy is the visual strategy. And so this is the leaflet that we created for the intervention, and it describes the way we detect colorectal cancer in a very simple way with very short sentences. It's written in big font so that it's easy to read. And all the sentences are accompanied by illustrations or pictograms so that everything is easy to understand and everything is clear. And there is a clear definition of who it's intended for, why we do this type of thing, and how you actually carry out the screening process itself. And I don't know if I have enough time left. I've got 1 minute left. And so I would like to show you one of the videos that we made for the physicians and for interventions by the doctor. So my name is Jacqueline. I'm 59 years old. I live in Saint-Denis. Hi, my name is Rachid. I'm 68 years old, and I live in the northern suburbs of Marseille. We're going to be talking about the test by showing an envelope. And once I got home, I looked at the user instructions, but I didn't understand how to use the label, so I ended up throwing everything away. For me, it was very easy. At the end of the visit, the doctor gave me an envelope. Once I got home, I looked, but it looked too complicated. And so it's been 2 months that it's now been hanging around. The participants had difficulty understanding the information provided by the doctor. And because they didn't understand, they didn't feel like they were skilled, and they lost motivation to do the test. And in terms of the potential stakes, there was a lack of engagement, a progressive lack of engagements. So health literacy means the capacity to obtain, process, and understand healthcare services so as to make an informed decision when it comes to your health. And as such, it's very important that patients understand the information they receive and are able to understand it to effectively navigate through the healthcare system, facilitating interaction with healthcare professionals and being able to manage their conditions themselves. So 44% of the French population are limited in their literacy. And this means they're not able to process or understand healthcare information. And so they are, as such, they're unable to make the right decisions. Hi, I'm going to give you a kit to screen cancer of the colon and the rectum. And so this is called cancer of the large intestines. Have you heard about this already? Well, very quickly, but I don't know what it is. It's a free test. It's a test you can do at home, and it enables you to see whether you've got blood in your poo. And if the test finds blood, it's maybe because you're suffering from a polyp or a cancer. And so this can easily be removed. Thanks to the test, we're able to detect whether you have cancer or a polyp, and we can find it early enough to treat it. Do you have any questions? So how do I carry out the test? How do I actually do the test? And so this is a type of training module provided to physicians which shows them how to explain the screening test to their patients. Thank you very much for listening to me. So we're now going to carry on. We'll be carrying on with Philippe Martin. And he works at the INSERM and at the MINED. And he is a specialist in sexual and reproductive health and rights. So thank you very much for having invited me to speak to you here today. And once again, I would like to tell you about a project called Sexperts, and this followed on the thesis I did. It was a study done with an online community, and we wanted to see to what extent is digital and health literacy taken into account when it comes to promoting better health. And thinking in terms of the young population, they have different types of considerations which are linked to sexual and reproductive health. When we think of public health, we think in terms of STDs, violence, risks over the internet, unplanned pregnancies, but it's also based on other types of behaviors. It's about having respect, good communication, having consent, and contraception, as well as upholding gender parity, gender equality. And so there are a number of themes that are linked to people's love life and their sexual and reproductive health. And so it goes beyond the usual indicators, and there are notions of pleasure and non-discrimination. And so there's a definition by the WHO that defines it as it's a state of well-being linked to one's sexuality. And the recommendations entail how to prevent STDs, violence, and undesired pregnancies. But promoting good health goes way beyond that. The aim is to promote well-being and healthy sexual life, all while respecting people's rights. And so I've included the national strategy and the guidelines issued by UNESCO, and which promote a participative, interactive, holistic, and positive approach, as well as promote the use of new communication tools. So the reasoning is, given the different experiences of the young population and the need for education in the field of sexual health and health promotion, the question is, how can we understand the needs? What actions would be the most attractive to them, and what is feasible and acceptable to this population, given their different ages and the different context, and what are the conditions for implementing these actions? And via research, how can we see whether these actions are effective and at what level? The aim of the presentation is to also to consider health literacy and digital literacy as a determinant. It's a lever for action in terms of promoting good healthcare. And we need to see to what extent there is a correlation with social and health inequalities and reducing these inequalities. The aim is to provide for scientific knowledge based on proof, to provide for more informed decisions in terms of public policy. And so health literacy is either a contextual or a factor or a determinant. And what we're trying to do within this project is we wanted to see to what extent this literacy can be considered considered in the framework of scientific research. What role does it play in preventing and promoting better health? And so I wanted to show you how Sexpert came to be. How did we develop? What are the major outlines of the program? And our considerations for the different determinants. I'm going to be showing you a theoretical module just to show you how we developed our action and how we approach its assessment for a population of young people who are very diverse. This is very often a very sensitive and private theme. That's sexual health. And we wanted an interactive community, a participative community who participated in line. So it's the aim of Sexpert was to assess the efficiency of an online interactive and participative community of action. How does it influence favorable behaviors? And we had an online cohort and randomized controlled trials with a longitudinal and individual follow-up to see how sustainable their behavioral changes were. And I wasn't the only one involved in this research. I worked alongside many colleagues and other organizations, and I'd like to thank them in passing. And we got 4 years of financing in order to fully execute the intended research. Now, in terms of our methodology, we started off with a theoretical model to test. So that was the thesis that I wrote. I went out to question young people, professionals, and the theoretical model was then used as a basis to define the components of our action for the prevention and promotion of sexual health. And we developed online tools that were most adapted to the youth, as well as were feasible in terms of the sought-after effect. And all of this was done on a participative approach. We tried to develop our content for the youth and along with the youth. So the aim of the project was to implement this intervention and assess it. We call it a complex intervention because there's several aspects to it. There is aspects that are informational, interactive, and participative. And so here is a copy of the model. This is a model that covers behavioral change. It took us several years to put it together, and we still feel quite traumatized by the model. But the aim here is to show you all the determinants that determine behavioral changes, everything that was identified. And for each of the determinants, we associated it with an indicator, a measurement. And so we also integrated the notion of health literacy. And we also want to integrate the notion of a digital literacy to see if there is a correlation and if digital or health literacy can have an impact on behaviors and behavioral determinants. So the tool is a web app and a website that will be implemented in 2023 for teens and young adults. And so we will involve young people, different healthcare professionals involved in sexual health, as well as other existing resources. The aim is to have different systems and have them all complementary to each other. And so the question that we broach is how can we improve health literacy within a campaign aiming to promote sexual health? And so it's considered as a determinant to be improved or an aspect of context. And within the framework of our action, the aim is for us to be able to appropriate information when it comes to sexual health, and notably for sensitive and private issues that you find within the field of sexual health care. The aim is also to see to what extent education by peers could be a leverage and a means to share knowledge, as well as to we also wanted to see how, at the end of the day, we can send youth to the appropriate healthcare services according to their need, and by also being able to anticipate their needs. So there are some assessments that have been provided for within Sexpert, and we wanted to set the target, who are we able to reach and who aren't we able to reach, and to see what is attractive to whom in terms of components of action. And we wanted to describe how these actions would work, what effects would be produced, and what effect would it have on literacy, and what positive change could it have on sexual behaviors. And so there are several concepts that were taken into account. There's health literacy applied to sexual health, digital literacy. But at the end of the day, we'd also like to think about the notion of organizational literacy. And the question is, how do we create environments that are favorable for the youth? So the literacy is a contextual factor of individuals who are involved in prevention and promotion of health actions, as well as a determinant to be improved in the framework of actions that could intervene in the entire mechanism. And so this last slide, it constitutes certain points for discussion, notably when it comes to the feasibility of this type of system. Is it easy to apply this type of experimental plan in the framework of research to assess and test actions? And we're waiting for the first results, notably in terms of the application of our experimental design. There's also a question of indicators. How do we measure health literacy? What are the criteria that we use to judge based on the different sexual practices, different partners, as well as different aspects of people's love life and their emotional life? How can we understand those actions aimed to the action mechanisms? It's not really a very easy thing to measure. And how are we going to understand the effect of participation and social interaction online? This is also one of the drivers that we did identify. So how should we consider literacy? Is it should it be considered on the basis of context, or is it a determinant which depends, which is associated with effect? And we have to take into account potential bias, something that we always have to consider in the framework of our research. There is the selection bias. In sex pairs, we try to have a sampling that was representative of the generation itself. It was done randomly, but it proved to be complicated in terms of reaching and communicating a younger population. There's also the bias of desirability, and how far are the youth willing to go in terms of the declarations they make, faced with the different standards, the sensitivity of the topic, as well as all that's expected of them in the field of sexual and reproductive health. So thank you very much for listening to me.
Bien, merci.
Thank you very much, Claudia and Philippe, for these two presentations that I think filled the contract, met the contract there. So questions then. Up to the audience there. Thank you. I have a question on the colorectal cancer screening program. I was wondering if you had a territorial approach, say, beyond, say, individual interventions with the patients and doctors. Is there some sort of community-based dynamic, community-based momentum in the territories, or where you're experimenting this procedure? And secondly, a kind of related question, you mentioned clear communication, and you presented a certain number of instruments there that you've developed. Were these developed with the users or inhabitants? Is there any participative efforts there? First question. This was conducted in underprivileged areas of the 4 different regions, Occitanie, Ile-de-France, Aura, and PACA. And so it was the EDI, that's an index of a European underprivileged index. So we targeted the private physicians' offices in these areas. Now, regarding the participative aspect, the entire project was conducted with participation for developing the brochures and the videos. In fact, everything was done with our community advisor. We have patient partners who are part of the steering committee of the study as well. Another question. Hello, thank you for the presentations. I'm from Santé Publique France, and my question is for you on the second presentation there, so I can get a good understanding. These are not really topics I'm that familiar with, so your theoretical model and then your application there, if I understand correctly, you're going to insert that in a prevention action in sexual health care. So to measure the level of literacy, if I understood correctly, and then the efficiency of the action in the field of literacy, are you going to do some before and after, or the control groups? I don't understand that. Yes, we have some measurements that we're going to do at T0 or in the beginning. Short questionnaires for young people because there are a lot of determinants. But so we'll be testing the feasibility of comparative studies across platforms where there's an action, and then we compile the data from questionnaires and then monitoring this before, during, and after. Thereby trying to include depending on the inclusion of the youth in the platform there. So 2 different ways then for evaluating, assessing that. So we'll be following the cohort online, and then there'll be a randomized control test. We'll be checking certain actions at specific moments, but that's a hypothetical for the time being. There's reality as well. If we can manage to take stock of certain effects, we'll look at to what extent there is a connection between the various determinants over time. Right, thank you. And additionally, just to make sure I understand, when actions are implemented, is it not necessary to control the coverage of the group and protect the non-exposed group? If I understand, you'll be using controlled and uncontrolled groups, so that might be a bit complicated to make sure that the control group isn't exposed during the intervention. That is one of the biases that we've looked at when putting together the project. There's the bias of contamination, because a young person can transmit the link, and then someone in the control group and outside the control group. So what we want to do is measure through questions as they enter into the community to see how someone got to know the community of experts, then to try and judge through declaration if there's contamination in the group. But that is still to be discussed and debated from a scientific standpoint. Thank you. Any other questions? Thank you for the presentation. Still representing Arena. As regards to colon cancer, we know that the coverage is too weak. The most recent publications have demonstrated that it would be a good strategy to get good coverage, but the remaining doubt on the screening program is how can we achieve sufficient coverage so that the screening program is enough. That's not the case right now. So I have 2 questions. One is post-protocol. What's going to happen? Have you thought about how, let's say, the protocol does end up being efficient? We could then extend that. And how would that happen? Second question is as regards the coverage in colon cancer. It's insufficient. It will always be insufficient because we know it's increasing also with the coverage is increasing with an increase in the socioeconomic status, but it's still insufficient. So maybe we should carry out this experiment in a more favored or medium type of a socioeconomic status. Well, quickly, and it's still ongoing right now, but qualitative assessments are planned to perhaps carry this out across all of the French territory. And the data shows that the screening coverage is too low across the entire population, which is why it's important to increase literacy. I think it's it would be important for people who don't have even low literacy, what we could define as low literacy, but help them understand the importance of screening to the entire population. So then ideally, of course, we would need to achieve 100% coverage, of course, but that might be idealistic, but at any rate, I do know that amongst my friends and family, a lot of people are not getting tested because they don't see the point. They think it's not important. They're not worried about it, but these are these misbeliefs or misconceptions based on I don't know what. So this would need to be conducted across the entire population, regardless of their literacy level. But the message I'm trying to get across today is, with what we've done, what we've tried to create, so far as it's important for, say, screening, testing, it could be, that could hold for any and all other diseases and medical exams. It's educating GPs as well to talk about these things more simply with less medical language that intimidates people, and people often don't understand. And sometimes patients won't dare to say, "I'm sorry, I don't understand what you're saying, doctor." So then they go home and they don't know what to do. Any other questions? I have one for Philippe. I'd like to know how you intend to identify this outside involvement or outside interventions for your project, such as Santé Publique France health campaigns on health, such as sexual health as well. Of course, we've identified all of the existing programs. Part of what we do is a connection, a link to existing resources, and that's including the on s'exprime.fr, we express ourselves.fr. Like other websites, we have a mapping of santé.fr that gives you the various websites on sexual reproduction, sexual health care for young people, where they can ask questions and the things that can go beyond just the field of sexual health and other questions that people might want to ask. And then we're also trying to implement set up help on violence and sexual assault to provide assistance there, because we need to be very responsive, connecting there to the departments necessary. I was talking about this with some people here today. There's some changes in the whole system that need to be that are fast, and we need to be up to date on what we're doing and keep everything up to date. But that will be one of the resources. Thank you. Any question back here, right online? Do you have any advice, any documentation, as regards to connection between health literacy and promoting health care with working with associations? I think that's for everyone. No. Wait, could you repeat the question, please? Now, do you have any advice, any literature advice on the connection between health literacy and health protection, focusing on associations and their action? Specifically on associations, no. I'm not sure if you have any. I don't want to answer for the speakers, but I'm president of the National Federation of Education in Health, and without any, if I'm not mistaken, there's a FNES website. There's a bibliography there that is sort of an answer to the question there, and you should find that on the National Federation of Education and Healthcare, FNES. Can I ask another question on colorectal screening? Today, as healthcare is offered, we're seeing less and less healthcare professionals working in an isolated fashion, meaning there's coordinated exercise, and they're recently working with these developing these multidisciplinary health centers. So we're seeing instead of attending physicians, we're seeing attending teams. You can have psychologists in there as well. So the whole procedure that can be implemented to promote colorectal screening can often be in this coordinated clinic structure or center. So the PCP or GP or attending physician isn't isolated. So this dimension it's focused on a lot, but I think most HCPs are working in centers. And some are still isolated, though. Some of the doctors who participated in our study work in these centers. We have nurses working with them, and they were trained in the trial as well. So the doctor would often hand over to the nurses, and they would present the screening and the trial. So it has been done. A lot of doctors, not all of them though, some offered the alternative there for sure, and that was taken into account, and that definitely can be part of a strategy where, of course, doctors are overwhelmed, don't have enough time, their appointment time, consult time is really short, so this strategy could be nurses presenting the screening campaign optimally. An additional question to the one online, there are articles with the connection between healthcare and health literacy. We can share those if you're interested, and we'll have Denis Menner, who's going to talk to us about culture and health, and perhaps give us shed some light on what associations are doing in promoting healthcare and health literacy. Thank you, Cécile, for that transition. Now let's move into the second phase of this roundtable discussion. Hi, I'm Virginie Rengar. We have 3 presentations, 10 minutes each. Yeah, sure, you can stay. 10 minutes each. At the end of these 3 presentations, we'll have 20 minutes of discussion. So the first one is Aurore Marga, who's a lecturer, and Paul Kenne, a researcher at LEPS, and Rabiatou Kamara, ambassador on a project all about a project they're going to present to us in People's Health Academy. Thank you very much to the organizers for enabling us to present the Popular Health Academy, the People's Health Academy. It's training, it's promoting healthcare and looking at specifically literacy and health situations and health literacy. You'll see that. Now, I'm going to give you the results that we're presenting in descriptions. We don't have cohorts with thousands of participants. The goal is ultimately here to offer up proposals regarding health literacy. Now, this said, let me get started here. So, just to get going, it's a territorial context in La Seine-Saint-Denis. It's north of Paris. There's great inequality there, health inequality as well, accentuated from the COVID situation. So it's in this context where we set up the People's Health Academy to address some of these issues and get the folks in this area to become health ambassadors in their department, in their county. So many stakeholders in the project. We have the department Seine-Saint-Denis, and they were watching online, so I would like to thank them. They've helped us organize the project at LEPS. That's the laboratory of promoting healthcare, and they're in charge of the research. CODES helped us in engineering and implementation, and funding coming from the BNP Paribas Foundation. So, as I was saying here, it's training, 1-year session with several competencies, skills and competencies for our ambassadors to be able to facilitate access to healthcare and health educate in their community. When we say community, that's in the broadest sense. Now, to do this, there are 9 days of theme-based training, with the goal being to work on co-constructing in healthcare knowledge, educational skills through exchanges with experts, exchanges that we wanted to be co-constructed, educational learning, and then reflection time to develop skills. So 3 days with some support by Codex 93 department. They're helping the ambassadors to implement the programs in their territories and working with the people that they choose. All this is accompanied by the departmental council with degrees and university recognition at the end of the program after a year, and we can come back to that if you like. Now, it's a skills-based approach. As we said, there was engineering in it. We based this a lot on healthcare, family healthcare education to create the whole system. I'm going to hand over to Paul. Okay, just a few words here about the studies that we conducted here on the system. When I say studies, or it's because the program is now in its 3rd year, and so far the results, in fact, are to be published in the upcoming days, were to understand the effects of the program for the 2 ambassador populations who participated in the first 2 years of the training. So we have organized the results based on the Kirkpatrick model, which takes into account the reactions of the participants, the actions that they've carried out, developing their skills, and how they've handed over, or how they've transferred these skills to their community during the training. And then the last section there, which is remote learning, or learning later following the training. So today we'll be focusing on these learnings here, where we have health literacy, and the level of these of their literacy is part of a marker for the learnings. So since we don't have much time, this is what we're going to focus on. So quick words here on both the 2 graduating classes. We had 30 participants, mostly women, aged from 20 to 79 years old for the first graduating class, and then 28 to 78 in the second group. So all of these were residents of the Seine-Saint-Denis region, north of Paris. Now, following these 2, we had 2 years. We had 21 ambassadors who received degrees. Now, as regards to health literacy, what we were able to see is in the beginning, we use the HLSQ and the 16 items, and so we measured pre-testing in the beginning of the training and at the end as a post-test. What we saw was that there were comparable levels in the beginning across the 2 graduating classes. At the end of that 1-year training, we saw that the average score of the test increased. So you can see for the first year, it goes from an average score 12 to 13.7, which goes from a problematic category to a sufficient category as regards to questionnaire. The second class, we had an increase in the score as well, and all things considered equal. We had a small sampling, of course, but for the second graduating class, the results were significant, meaning that there's substantial progress average-wise, but also in the breakout across the categories. Because for the second year, we had no ambassadors at a problematic score level. Back over to you. Okay, well, the points that are interesting here, it's quite frustrating to be able to give this report in just 10 minutes. We had some very favorable results at each level in terms of the reaction of the learning, skills and competencies and transfer and results. And it worked. Go ahead and run the slide through there for me, please. It worked because we can say that we based this on promoting healthcare and the pillars of the Ottawa Charter as a fundamental part of the program. So we created a favorable environment. It was co-construction, intersectoral, and we increased the individual skills, yes, but also we ultimately promoted engagement across the participants. So in conclusion, before I hand over to Radia Ratu, who's going to share her experience, the research is continuing, as Paul said. Results will be online in the upcoming days and being continued across 4 main themes that we need to cover. Exposition to the greatest number of people, with the tests of be kicking off on shared literacy or distributed halo effect, of course, and then also based on the Popular Academy, the People's Health Academy, and a possible driver against epistemic injustices. So i.e. distance from the training, transferability of the program with a realistic evaluation, assessment of it, and then finally working on the engagement, the effective engagement of a professionalization of our ambassadors. And now handing over to Rabietou.
Donc, bonjour à tous.
So, hi, everybody. And I'm really happy to be with you today. And when I applied to become an ambassador for the People's Health Academy and work with the department, I never thought that I would be faced with all of you today. And I've been well trained and I've been well supported and I've been reassured. So it's a bit emotional for me to speak about this. And I always say that every time I begin, because apparently it makes it creates a kind of a gentleness with the public. And the reason why I decided to apply in the first place, I live at Pierrefitte-sur-Seine. It's a town which is between Saint-Denis and Sarcelles. So it's in the department 95. And so during COVID, there were several of us who came to the realization that there was different information circulating. And there was so much information that was circulating that we didn't know what was right and what wasn't, what was a good information. So there were things like if you don't want to catch COVID, you have to eat 5 fruits and vegetables every day. And so I thought, okay, that reminds me of an ad I saw when I was a kid. Or you need to consume a lot of dairy products because the advert says they are our friends for life. And so that would be means not to catch COVID. And so much as to say that there was tons of information. We didn't know what was true or what wasn't. And so I thought, okay, I'll apply for this program, and at least then I'll get the support of a structure that could provide me with training and can give me the skills that I need. I wanted to be part of an organization that would consider me as an individual, and they wouldn't treat me as if I was a child. They wouldn't be condescending. So in terms of the different actions that were carried out, there were several initiatives. And all the experience we had had in nutrition, neuronutrition, and sexuality, we drew upon that experience. And we went to the different associations to speak about this. Within the Academy, there are several of us who are members of the association, or we are part of other organizations. And today, we are an association. So it's a combination of several associations that are joined together to become health ambassadors. And we promote healthcare and health education amongst our different communities. So when I speak about communities, communities can mean many things, actually. It could be people from the same ethnic background as yourself. It could be people who have the same profession as you do. So it includes all of that, different types of communities. And I'm speaking on behalf of my group, but it enabled me to obtain certain skills and to be able to make use of those skills in our different initiatives and campaigns. I know I don't have enough time, but we did what we called Café 10. I would have loved to have showed you the photos because it was really great. Café 10. And so 10 as in dyslexia. We had atypical brunches. We also had awareness raising for breast cancer. We also did what we called atypical boxing. And so there was a lot of work done on raising awareness to invisible disabilities, invisible handicaps. And what we did is we listened to the people. We tried to listen to each other and to provide for ideas and further each other's knowledge. And this gave us access to so sorry, you cut my line of thought. But what I was trying to tell you is it all started with the population, the people around us, that we sat together at a meal, a brunch. We had a discussion, and on the basis of that discussion, we tried to create an activity, an initiative, something that would spread information. And so during the brunches, for example, we could work on LDPH. And what we often tell people is that we are not healthcare professionals. We are just a link. We're a link between our community, the general population, and those institutions that surround us and that we come to interact with. So thank you. I'm sorry I had to cut you off, but thank you very much. And so now we're going to have a presentation by Denis Manaerts. And he works for an association called Culture et Santé. They're based in Brussels. And you have 10 minutes. So thank you very much. I hope everybody can hear me, says our speaker. So thank you very much for hosting me and having invited me to speak here at Santé Publique France. And I would like to tell you about the experiences that we had within a French-speaking Belgian association and tell you about what we have done to further our health literacy. And I'd also like to talk to you about advocacy and to tell you about what we've done alongside other actions has enabled us to progress in political circles in terms of promoting healthcare and promoting health literacy. So we're quite an old association. We're 45 years old now. And we combine health prevention and education of the people. And we are active in Wallonia and in Brussels, so the French-speaking part of Belgium. And our social goal focuses on social equality in healthcare. And one of the drivers that we make use of is we'd like to promote more equality. And so I have been focusing on the mediator factor. And we've tried to work on better health literacy. And so since the turn of the century, we've been working on health literacy, the promotion of health literacy with different initiatives that I will tell you about during the course of my presentation. We have published several resources and tools that have been disseminated. We provide for vocational or professional training, and we also lobby. We advocate. And so we have different levels of action, all aimed at promoting health literacy of the general population, with an action relative to individuals and groups through the different processes that we've spoken about, educational processes, upskilling people, helping them to develop, empowering them, working with communities in a participative mode. And we've also worked at a more organizational level, working with professionals, working with various healthcare organizations and social healthcare structures, helping them to work on their practices and the way that they function, making them more aware of the importance of health literacy. So that they can contribute to furthering a better health literacy amongst the population. So this is a level of action that we are particularly invested in. And we've created training relative to health literacy at an organizational level in the field of healthcare. And another level is more of a political level in terms of lobbying and advocacy. So creating more of a structural context, a context that's more favorable to promoting health literacy. And so health literacy, we wanted to inscribe this on the political agenda. And so within Culture et Santé, the different drivers that we use for our lobbying or our advocacy efforts. So we work very close to the field, right through to expert level, with initiatives carried out by different population groupings. And one of the first things that we do is we try and see where opportunities exist. And when it comes to health literacy, we see what opportunities can be grabbed. So we have a project management team that is on the lookout for everything that's happening in terms of data, relationships, and current political news so that they can insert the issue of health literacy and put it on the political agenda. The second thing is that we try and develop our own network of parties, Peters that we train, people that we support in a company, people that we collaborate with, and working with different organizations. And we take every opportunity to speak to them about health literacy and see how they can include this in their own actions. We also try to meet with strategic actors, whether they be politicians, people working for consultancies at the administrative level, as well as all those that work at the intermediary level. Anybody who might have an influence on political decisions made and who can help to put health literacy on the agenda. And Culture et Santé, we also have a seat on various boards and bodies. All those that advise our leaders and raise their attention on certain issues. And basically what we do within the Culture et Santé is we promote health literacy. We also communicate a lot on our website. We have a newsletter, we publish articles, and we also give presentation at symposiums and conferences such as this one. These are opportunities for us to share our view of health literacy. And one of the most important features in order to have impact is that no association could produce the desired impact all on its own. So we have created alliances in order to further promote health literacy at a more structural and political level. So we collaborate with the World of Research, with the Catholic University of Louvain, the University of Liège, who are very much in the know when it comes to health literacy. We promote studies, we provide for data, and we try and convey common messages. And we also work outside of the public sector. So the CASU, as well as the INSI-SANO, who have produced reports. The KCE produced a comparative analysis of different policies in the field of health literacy in different countries. And there's Science-SANO, who have also published data linked to the level of health literacy amongst the different population groupings. Another alliance, we work with funds and foundations. We have a foundation in Belgium that has a strong focus on health literacy, and it's the Fondation Roi Baudouin. They finance different projects promoting health literacy. And they also use all the data collected from these projects to learn different lessons and to promote messages at the political level. And they were involved in publishing a report that highlights the different results from the different initiatives carried out by NGOs and their contributions to furthering health literacy. And even if it's not a scientific document, it suggests various methods of intervention and various approaches that are very interesting. We also work with various strategic structures, like insurance companies who are now beginning to consider health literacy in their strategic plans. We also collaborate with various peer associations, such as health promotional federations, the FWPS and the FBPS, who also have policies relative to furthering health literacy. And all these strategies have enabled us to help literacy and health literacy to progress. And here I'm focusing on the promotion and prevention of these policies in the French-speaking part of Belgium. Our organization is funded by the regions, whereas actual healthcare is funded more at the federal level. At the federal level, there's less room to have impact when it comes to promoting health literacy. But we have more of an impact in prevention and promotional policies at the regional level, even if the financing involved is more modest in nature. And so this was something that almost didn't exist 10 years ago, and at least it didn't exist in this format. Maybe it was something that existed in other formats, but it's now been included in all the health promotion and prevention policies in French-speaking Belgium, whether it be in Wallonia or in Brussels. As regards the Brussels plan for promoting for health promotion, developing health literacy is now a structural principle, and it's an important feature of the plan. It has been defined, and all those who require funding are able to refer, or I'd say they should refer to this feature. It's considered to be a strategy applied across the board, and it's something that now has to be a mandatory part of their action plans if they are to acquire funding. And in order to support and accompany all of this, there's also a support department who is there to help actors to integrate this aspect of promoting health literacy in their action plans. In Wallonia, it took some time to emerge, but it is present in its operations and in healthcare. And so this is one of the strategies. So, for example, when you are combating chronic diseases, preventing chronic diseases, there are certain healthcare literacy strategies that can be implemented. And so it's also included in other action plans. So there's the integrated social healthcare plan from Brussels, amongst others. And I'd just like to also talk about some of the challenges. And it's also echoes some of the things we heard in the hall a little bit earlier on. But one of the major challenges we face is that health literacy needs to be developed further and be densified. We need to be able to have a more complex approach. And it's not just about observing, applying, and observing, but we need to make use of health literacy as a means to emancipate people so that people can become more empowered, not only on the individual level, but on the collective level as well. And we also want to make use of relative data, making us more visible, with more emphasis on individual research. We'd also like this to be put on the educational political agendas. And we would like health literacy to become a criteria according to which we assess and measure the quality of a healthcare system. And this isn't the case to date in Belgium yet. And so now I'd like to call upon the last speaker for today's session, which is Mounia El-Yamani from Santé Publique France. And Mounia will be telling us about Jacadi. Xavier mentioned Jacadi a little earlier. And so you have 10 minutes, and then we will open up the floor for discussions for 20 minutes. So thank you very much. And I'm going to be speaking about a European program, and which has been quite well funded. It's called Jacadi. It's a joint action on cardiovascular disease and diabetes. And so within Europe, in principle, public health care or promotion and prevention of health care is not a European prerogative. Europe finances research in the field of healthcare as well as healthcare networks, but they don't necessarily finance field actions aimed at prevention and healthcare promotion. And so progressively, things started to change, especially with the EU for Health program, which was introduced just after the COVID pandemic. And in reaction to COVID, it was then adopted because people realized that we needed to be better prepared for any crises within the EU, having more robust and resilient and more accessible healthcare systems. And so Europe invested 5.3 billion euros intended for 2021 to 2027. This is an unprecedented budget in the field of public healthcare. And it's going to be invested in 4 actions aimed at improving and promoting healthcare, protecting people, strengthening healthcare systems, and making access to medical devices and drugs easier. When it comes to improving and promoting healthcare, this is the section that we're particularly interested in today. And I'll be talking to you about Jacadi, which was carried out in this framework. So healthcare promotion and preventing disease was made a top priority, not only in terms of combating chronic diseases, cancers and non-communicable diseases. There have been systems set up for international cooperation, focusing on healthcare issues. And so on the basis of this decision made at European level, so that is to have actions to prevent and promote the curing of chronic diseases, the premise was to provide, to carry out several joint actions, one with a focus on cancer and various determinants, which I won't tell you about because we didn't apply to work in that field. But JCARDI, that is the program that we're working on, and this is for cardiovascular disease and diabetes. And so by focusing on diabetes and cardiovascular diseases based on well-known figures, the fact of the matter is that chronic disease is a heavy burden. It's a heavy financial burden within Europe. A third of the EU's population, adult population, has at least one chronic disease or a long-term disease. And if we were to tally the priorities for non-communicable diseases, they are responsible for 75% of deaths. And so the biggest cause is cardiovascular disease, followed by cancer, followed by diabetes. And that's why it's so important to have a policy for action and prevention, which will help us to have better control of the costs. And Europe's point of view or vision is always a pragmatic one, but it's also financially driven. And by combating these chronic diseases, it enables us to reduce our budget as well as have keep people healthy, people who are able to work throughout their lifetimes.
So the JCARDI scope is to implement the best practices, experiments, and transpose innovative policies and practices and policies in line with the Santé Publique Française, which was disseminated with EU NCD initiatives. That's a European non-communicable disease initiative, interventions with the populations and across healthcare systems, across all policies. Someone said you needed to put this on the health literacy on the agenda for politicians and policymakers. This is one of the heaviest weights, and preparing techniques and rolling out training for that and strategies and communication and reinforcing literacy. We need twinnings and information regarding healthcare. Now for JCARDI, which is to combat cardiovascular diseases and diabetes, and this is a 4-year initiative, and starting at the end of this year and going through to 2027, with a budget of 54 million euros, which is considerable, Europe-wide for a joint initiative, with the goal being to reinforce prevention strategies, reducing the weight, the charge, the load of and the morbidity, and improve sharing best practices, best healthcare practices, with 2 transversal pillars supporting it. One, fighting health inequality, mostly amongst the most vulnerable populations, and having producing quality data that can be used for public policy and public health actions. So 21 member states in Europe. And as it's an action including many countries, so 21 members, different European rules, the EU taking covering 80% of the budget and all of the actions carried out under the JCARDI helm. If I go into greater detail here, and I try and look at what's going on in health literacy, here we have what we call the work packages, the WP here. This means all of the initiatives carried out and summed up in 6 themes, 1 being transversal, 1 cross-cutting, and 5 being vertical. And one of the most important is health literacy for improving and awareness raising, better information and awareness on diabetes, cardiovascular disease, and their risk factors. So it's this action, this area, this work package where France Santé Publique France has gotten involved, and we are the leaders of that work package. So, and exclusively on this work package, we had 15 member states involved to work on health literacy. Several partners across 24 across different countries, 24 of those. So Europe then has pilot programs. So in this work package, we define the framework, and then we ask the participants or the partners to propose pilot programs. So we have 27 health literacy programs, pilot programs that were proposed under the Jacques program. So here, work package 6, health literacy, to develop and promote pilot programs able to generate large-scale reductions of the weight or the charge of this. We need to measure. We have to. We'll measure at the current time, and then we'll see the reduction of the weight of these diseases in diabetes and cardiovascular disease, and then harmonize a large number of pilot programs to create and formalize a network. Okay, then I'll just skip through all of this. Fine, no worries. Okay, I just hope that I can express that through this work package on health literacy, there are actions, there are tasks being carried out. First being to map all of the actions in health literacy across the participating structures, defining the local needs. And that comes back to the action that was described earlier, starting with a local need, and then prioritizing health literacy actions that need to be carried out, and then at the end of it, assessing all of the programs. 27 pilot programs, that's a lot of populations involved, be it professionals, be it fragile, vulnerable populations. In Santé Publique France, we have an action. Xavier Dubuche talked about that earlier. This is for diabetic patients, people living with diabetes, and women who've just given birth, who perhaps have hypertension or diabetes. There'll be an SPF action there. There'll be others also, say for children. The Spanish have a health literacy program for children. We need European Union requirements to identify and implement best practices, committing to applying something that's recognized, published, and that can be assessed. Several methods have been published on this joint action. We've decided to partner with Richard Osborne, who's the promoter of the Ophelia method described here very briefly, and Xavier Dubuche talked to you about that earlier. And so the pilot programs, the pilot leaders are invited to use this method to apply health literacy. Thank you.
On est désolé de vous frustrer.
I'm so sorry for frustrating you, but otherwise we won't have time for the questions. So we have tops 15 minutes for questions. 15 minutes for question.
Bonsoir, merci à toutes les.
Hello, thank you very much for all of the presentations. I had a question. And I'm from Marseille. I work in Marseille. I had a question regarding the APS training. Do you have an explanation based on the fact that second training session worked, the ambassadors said the second training worked out better than the first training session? And secondly, is there a lifelong or ongoing training program for the ambassadors? Because the healthcare world changes and develops every day. Are there any plans to or is there anything to understand why that one session worked better and how we can keep everyone up to date? Let me take this. As regards the various assumptions on the fact that it worked better the second time around as opposed to the first, I think it's the fact that we had a skills-based approach the second time around based on a very clearly defined educational model, and we worked more on reflexivity of our learners in the second session. So those are part of the assumptions, but also this is something we're going to continue working on, but that's essentially the point that's changed, that was different from the first to the second session. Your second question, I want to say, no, we don't have anything programmed, and so much the better, because the idea is that they are to be autonomous. Perhaps you can say this better than me. Well, the goal is for us to fly on our own, to take flight. So the idea is they've given us everything we need to move forward. Of course, we always welcome more information, more training, and knowledge is the only thing that you can keep giving and never lose. So our approach today is going and working with the populations, and they give us information as well. And so we just tend to try and communicate across the board. Maybe to add to that, maybe just saying that they are competent in seeking out information and scientific research, and that's what drives the program. So no, they don't have they don't have all knowledge like no one will. But the idea is that they go out and get that information. We're backups if they need us, but they'll continue to be in touch. The first group is in touch with, but the goal isn't to establish lifelong learning here. And I really want to stress the fact that it's co-construction. Because from the very beginning, they weren't patronizing to us. We weren't infantilized. I mean, we're adults. And once we've been cut loose, we can keep advancing, keep improving. Did you want to add something? No. Any other questions?
Merci.
Thank you. I'm a doctor at the Social Services in Paris. Now, regarding the training that you implemented, is it currently reserved only for people in the 93 department? Are you planning to extend that? Because I'm thinking about some of the people that we assist who could be really interested. And it could be definitely relevant for them. Well, right now it is only available for residents of the 93 area because of the partnership, and it's a very proactive departmental council. Before we can extend it, we want to make sure that we understand what's working and what works best. So we want to have that realistic assessment to provide other professionals and municipalities to develop sort of transferable ideas that we don't necessarily have yet. Thank you for your presentations. So my question then is on the funding of the actions. Especially in Belgium and yourselves there in the 93 north of Paris region. I think it's a departmental council, you said, for the funding? Yeah, go ahead. We're going to get our answer sorted while we hear from Belgium. There's no specific funding regarding health literacy, keeping in mind that health literacy is transversal. It's cross-cutting and everything. So there are stakeholders involved in actions in health literacy through their own objectives. So in Brussels, we have about some 60 associations that are funded by about 5 to 6 million for the entire program. So it's quite humble. I don't have the numbers in Wallonia yet, but it's a similar proportion. There are perhaps a bit more people involved, more parties involved. But it's insufficient, of course, to meet our needs. That's why these strategies that are being implemented are just second line at this stage, meaning supporting other actors, other people already engaged in health literacy actions. So here again, there's definite advocacy that needs to be, there's lobbying that needs to be carried out to get additional funds and cover the territories, cover areas where people live, and also spread the whole idea of literacy in other areas and other determining factors in health literacy. I just want to jump in here. I had a similar question, but your association, is it funded by the Royal Baudois Association? It's funded in the Brussels side by the French-speaking Community Commission. So that's Brussels, the Brussels area, Greater Brussels area, and the Wallonia side, an organization similar to Santé Publique France. It's a general public interest group, and they fund based on, in fact, they approve and then fund based on an action program with a whole host of operational objectives with a duty to meet certain indicators in a sort of semi-autonomous setting. So if you develop an action that is in a sort of general framework, and then from that standpoint, then you can get funding. Keeping in mind organizations that request funding, they get their funding. That doesn't cover all of their needs, of course, so there's funding that is indispensable to carry out the actions to promote health care that we're trying to do. Now, as for the People's Health Academy, the implementation, the training of the ambassador is funded by the BNP Paribas Foundation. Now, the ambassadors after the training, well, so far, any actions that we're carrying out in our own associations that we pool, we cross associations, if you will. Now, this is self-financing as regards the, it's volunteering, basically. I didn't understand what you said. We're not paid. No, we're not paid at all. Yeah, I guess I could have said that directly. I was beating around the bush there, but yeah. Yeah, no, so we're not paid at all. In the rooms that we can borrow to have our meetings. It's a local neighborhood. There's someone in my association. We have an association in our neighborhood that they lend us a restaurant called the Bocal. We have various social centers in the cities that give us a room, or give us a room in a school, or some larger rooms in settings like this. But so far, no funding, which means that as regards our actions, they're small scale. So if people come in, they're really small, minor actions at this stage. Any other questions?
Merci pour vos interventions.
Thank you for all of those very interesting talks. Tons of questions. I had one on training. We talked a lot about training. And I'm just wondering, in Belgium, what about initial training for healthcare professionals? Is that on the agenda? Is it there? Are there any plans for that? Well, there are initiatives that are currently being carried in terms of research. There are 2 research programs being funded to better include health prevention in initial training for frontline healthcare professionals, but also social healthcare professionals as well, more generally speaking. And right now, it's just at the initiative phase, such as culture and health. We're called on often by universities and other schools to come and talk, lecture, to raise awareness to community approaches or health literacy, and these other associations come in and just sort of punctuate certain points of the more general curriculum. But there's not enough attention given to this right now, the whole social dimension, cultural dimension in health literacy in the basic curricula. So there's definitely a project that needs to be carried out to really spotlight those aspects in the medical curriculum and paramedical curriculum, which is more the case in parallel professions. But it's gotten started, but there's a lot of progress to be made now, a lot less than in France. But we have time for one last question, and then we'll have the conclusion for today.
Question?
Does anybody have any other questions? There is a question, and this is for Denis Manertz. Which indicators are requested by the funders or the financiers, and which indicators are the most relevant in monitoring your field activities? Well, that's a great question. And I know that what I said was a little bit biased, and so the indicators are also compiled by the actors themselves. So they feed into a pool of indicators, and each actor can make use of the indicator that best suits their activity. At Culture and Santé, we try to make use of indicators that are observable. Whether it be observable during a first-line intervention or a second-line intervention, so something that's operational. So, for example, we provide framing on healthcare literacy and organizational literacy. And so we like to look to see how professionals have undergone our training, how they interpret and how they make use of these strategies on healthcare literacy in their own actions. How do they make use of what they've learned in their actual actions? And so there is a medium term and a long term follow up. And we follow up on the people that have undergone training with us to see the impact that all of this has had. And so there are different types of indicators that are more relative to processes and implementation. So it also helps to guide us in the criteria we use to create our training materials. Should it be based on theory, or should it be based on what we've seen in the field? So thank you. So thank you to all of you who attended the session this afternoon. And I'll be quick, but I just wanted to share something that struck me when I was listening to all of you. So the literacy in the field of health is something that's important, and that it's linked to social inequalities. And so we spoke about mediators, determinants, etc., whatever you want. But the current trends lead us to think that there are many inequalities in the healthcare field, and they're here to stay, and for several years. And our healthcare system's also becoming increasingly fragile. And that's probably something that's going to also be a factor in the encounter between an individual with the greater healthcare system. And so health literacy is going to become even more important and a primary factor, even more so than it is today, because these are two parameters. And even if I heard you being optimistic this morning, this is something to be taken into account in terms of our actions. And so the presentations given today, and I'd like to thank all our speakers this afternoon. I'd also like to thank all the participants to the roundtable discussion for the valuable information shared. It just shows us how important it is when it comes to understanding inequalities in the field of healthcare. And HLS surveys and the Ontrade surveys have shown proof of that fact. And health literacy is also a means to reduce inequalities. We need a pragmatic approach, especially given the fact that And there were different objectives, facilitating access to detecting cancers, for example, or having access to just general health information, seeing how we can speak to the youth or young people, speaking to them about specific issues that are relevant to them, and also taking interest in the more faraway populations, people who are a little bit further removed from the different systems. We also looked at healthcare policies. And so maybe this is where the most amount of work needs to be done still. And we heard examples that were quite inspiring, where it has been involved in the general healthcare policy, and notably in Belgium. And so you can imagine the role that it could play and the impact it could have on our own healthcare policy. There were examples that were shared in terms of what's been done in Brussels and Saint-Denis. There's much to be learned from those experiences. And of course, these are set to be extended and adapted. We spoke about the national healthcare strategy. And there were questions about what's busy being worked on at the moment and what hasn't been finalized as yet. And we need to keep a keen eye on the role to be played by health literacy and promoting health literacy. And while the session was being held, there was a parallel session where they spoke about the Green Alley. We didn't know how, but we saw that this session on health literacy is something that people are very interested in, because the audience was all there. The room was full. So thank you for attending the session, and thank you for staying, having stayed with us up until this late hour. So thank you as well to all those who provided for presentations, who answered your questions, sometimes under with time pressure. I'd also like to extend a special thanks to Virginie Rangam, who was the founder of the Refli network. And maybe we wouldn't be there if the network didn't exist today. And she is the founder of the Refli network. And this is the network that Santé Publique France has been collaborating with. And it's even gone so far as hosting meetings at her own home. And so the very first meeting that they have for the Refli network was hosted in her house. And I was there. And so I remember it really well, which shows the level of a commitment. And a big thank you to all the work that was done, enabling us to share the results of the efforts made, all the work that's been done. And if there wasn't this momentum and this energy within the network, I'm not sure if we would have had all these presentations here today. I'd also like to extend a thank you to Cécile Allaire and Annie Velter, who put together the program for today's session. And thank you for your daily support for this theme within the agency. So thanks to each and every one of you. And you are free until tomorrow morning. So thank you for attending and have a good evening. Bye-bye.